Today's webinar is brought to you by Centauri Health Solutions, who is a very long-time MHPA partner and supporter of MHPA and our health plan members. We thank them for organizing today's presentation, HR1 Cultivating a Framework for Success. And with that, I'm excited to turn things over to Linda Roman, who serves as Senior Vice President at Centauri Health Solutions. Linda.
Thank you, Patrick. Really appreciate it. I appreciate everyone's attendance. Thanks for joining us today. We know this is a topic of utmost importance to all of us as we work to carry out our respective missions. Today, I am so pleased that we have a really good panel with us. Joining us today is Jeff Jackson, Chief Operating Officer at Centauri Health Solutions, Laura Pence, Director at Levitt Partners, supporting the Enrollment Coalition, and Bill Snyder, Principal at Levitt Partners, supporting the Enrollment Coalition. Bill, if you could spend a couple minutes telling the group a little bit about the Enrollment Coalition, and then Jeff, if you could introduce Centauri, that would be great.
Happy to. Thanks, Linda. The Enrollment Coalition is convened by Levitt Partners. It's comprised of organizations committed to advancing policies to help those eligible for coverage to get it and retain it. You can see enrollmentcoalition.org for more information. We're happy to be part of the presentation today. Over to you, Jeff.
Thanks, Bill, and good afternoon, everybody. Centauri Health Solutions is a company that provides services to health plans across the nation, primarily Medicare and Medicaid services, but also some commercial and marketplace services. A lot of the services are associated with the concept of risk adjustment. So that includes traditional chart retrieval and coding expertise. We also are QHIN and are fully participating in the TEFCA network, trying to drive interoperability throughout the healthcare continuum for the benefit of all of us. And then most relevant to today's topic, we focus on special populations. We have the ability to identify, to reach, and to assist people in applying for and qualifying for government benefits. It's disability, dual eligibility. A lot of experience comes from the expiration of the public health emergency and trying to recertify people on Medicaid, LTC, and some other services. And so that experience informs some of the challenge that we expect as we talk about community engagement and medical frailty.
Thank you, Jeff and Bill. I think what we're going to do, just to get everybody engaged a little bit, is we're going to ask a polling question, and just if I can have Patrick help us with that. So the first question, how are you feeling about your implementation plans for HR1? Panic, prepared, planning, or perplexed? We're interested to see your responses.
All right, great responses so far. Thank you. Give it a few more seconds here for you. Still coming in. Nice. Okay, going once, going twice. Let's see those results.
Well, planning is good, and a few of us are still pretty perplexed, and there's a few of us panicked. So very good. Thank you so much for taking the poll. So I'm now trying to get my system to move forward. All right. So the initial reaction of many of us was panic, and some of us obviously are still in panic. But today we'll look at some key areas of HR1 and the implementation ahead of us. We'll discuss this getting ready period that we're in and how we can collaborate with our state partners. The goal, obviously, is to ensure that eligible members keep their coverage and minimize the cost of administration for our state partners and across the country. So I'm going to turn it over to Laura, who is going to get us started diving in with some key considerations.
Thanks, Lisa. And hopefully to get people from a little bit more of the perplexed and panic state to a little more of the prepared, which we didn't really have anybody in that category yet. like to start off with just a little bit of a overview and kind of big picture of where we're at, what the process of implementation is, and then some key considerations for that implementation. So just some things to keep in mind throughout today's webinar is really, we can expect that the law will change. And implementation is going to take time. So as we'll see in the next few slides, this is going to be a long tail of implementation. A lot of the changes and the expectations for reduction in funding is actually happening in future years. It's not actually happening in as much in these next couple of years. So we're going to see a long tail for implementation. The other thing is, it's going to dominate elections in the midterms. Going to have a huge impact on kind of how Congress is having its discussions over the next few years on healthcare. And one thing we can also look to is like past as precedent, thinking about, the Affordable Care Act and the number of changes we've seen to the Affordable Care Act since 2010. Particularly changes to the Cadillac tax, the so-called Cadillac tax, or even the individual mandate, kind of the changes that happened even years later after implementation. Congress also loves to change, laws after the fact with the sustainable growth rate in Medicare. So thinking about there are potential opportunities and concerns with additional changes that we've made to HR 1 in future years. And while we see some changes as potentially likely and maybe some smaller changes that we can talk about on the next slide, we just kind of want to note that we don't really see an expectation for changes in the work requirements in the next few years, particularly as implementation is ramping up on that provision. So that, we'll continue to see kind of as a fast and furious implementation for work requirements. So we can move to the next slide to discuss a little bit more of, some of what this is going to look like. So as you can see, this is the full map of implementation for the Medicaid provisions in HR 1. And you can see that a number of them are happening after the midterm elections in November 2026. And then even some of them are happening after the presidential election cycle in November 2028. So this kind of emphasizes what I was talking about at the long tail of implementation. Kind of on the earlier end of some of that is the Medicaid work requirements, which we're going to discuss in quite a bit of detail today. The other things that, we might see as kind of potentially impacts of midterms or future years as these are starting to implement is, we could see some sort of targeted changes on some of the provisions like carve outs for state directed payments. We could see minor changes to kind of provider tax flexibilities or even delaying some of the effective dates for some of these provisions. While those are certainly possible, we don't necessarily want to count on those things, but they could have a significant impact on implementation. The other thing that's going to have a significant impact on implementation is just there's a lot of opportunity for variations between states. And so taking a look, and we're going to do this in today's call, is, what is really up to states? What are we waiting on federal guidance for? And, what can we be doing now? And what is very clear in the law? We can move on to the next slide as well. And as I mentioned, this is a chart really showing kind of where the most significant spending reductions are expected to occur. And you can see it's really 2029 to 2034. That's where over $70 billion of the cuts is expected to happen. And then these two little lines up here, if you click the next couple of times, the over 76% of the Medicaid reductions are supposed to occur in those out years. And you can see on this timeline where the kind of midterm elections and the presidential elections line up. And just noting a couple of that first circle is the end of the good faith exemptions for states, so the end of 2028. You can see the significant increase in the spending reductions that are going to happen there according to CBO. And then similarly with the end of the grandfathering for state directed payments, we're going to see, we can expect to see a significant increase in the spending reductions that are going to happen in the Medicaid program. So I will turn it over to Bill to discuss a little bit more of implementation and what this is going to look like for states and providers.
Great, thank you, Laura. Want to give credit for the framework that we'll use here. Back in September, the acting director of CMCS, Caprice, at the time, participated in a panel about implementing work requirements. She shared how CMS was thinking about implementation at that time, and I thought the framing that she used was really helpful, and so we've reflected it here. She said the CMS was thinking about implementation in terms of areas where, one, the statute is clear, the things we know already. Two, the areas where states have discretion. And three, the areas that involve federal discretion. Subsequent slides will look closer at state and federal discretion, but here I want to spend a minute on some of the areas where the statute is already clear. One is that individuals who lose eligibility for not meeting community engagement requirements are still considered to meet minimum essential coverage requirement, meaning they would not be eligible for the special enrollment period to enroll in the ACA marketplace. Also, for purposes of Medicaid and CHIP eligibility, HR 1 limits the definition of qualified immigrants in a way that narrows eligibility. And I'll note that aside from the statute, there was also an important regulatory change announced in September regarding emergency services provided to undocumented immigrants through Medicaid. And then exemptions in the statute specifically exempt certain individuals from community engagement requirements. And those exemptions include Native Americans, medically frail individuals, which we'll talk about more later, dual eligibles, and others. So some elements are already known, even though definitions, like in the case of medical frailty, may require further guidance. These are some elements and provisions that are already known, we can already start planning and preparing for. So if we go to the next slide, then we highlight here some of the areas of federal discretion. And I want to talk about a few of those. Good faith exemptions, allowance of good faith exemptions for up to 2 years for implementation of work requirements. The idea here is that if states are working in good faith to implement, but are unable to implement on time, or they're at risk of not being able to implement on time, they can seek a good faith exemption. So here, HHS has discretion on the criteria used and definition of good faith efforts, and can even cancel an exemption that's already been granted if they feel it's warranted. In terms of standards, some examples of discretion here is, will HHS define medical frailty, or will they leave it to the states in some cases? And I'll also note here that some federal guidance is required by at least June 1st of 2026. The statute requires also, where possible, that ex parte verification of beneficiary compliance with requirements and verification of the mandatory exceptions. So this raises questions like how will HHS view whether or the extent to which states are using ex parte as much as possible? And then criteria. This is an area where HHS again has discretion, and it'll be interesting to see, and it's important as part of planning and preparation to keep an eye on. Again, will HHS define education requirements, or will they leave it to states? So for example, will states be expected to get data feeds from educational institutions? If I'm an applicant, can I just attest to taking courses? Do I just have to enroll in a course, or do I have to complete the course? Those are some of the considerations in terms of federal discretion. If we go to the next slide, then we'll highlight some areas where states have discretion relative to the implementation of work requirements. I want to highlight a few of these. One area is short-term hardships. The statute allows states at their option to allow short-term hardships for applicants if 4 situations are met, and then there's a little bit of extra discretionary space as well. But the four situations where states have the option to allow these short-term hardships is, 1, if the individual receives inpatient services in hospitals or other settings. 2, if the individual lives in a county in which there exists an emergency or disaster declared by the president. 3, if the person resides in a county where the unemployment rate is 1.5 times the national average, or at least 8%. And then finally, the fourth situation where states have discretion to offer these short-term hardship exemptions is if the individual or their dependent has to travel outside their community for an extended period to receive certain medical services. So that's the short-term hardship discretion that states have. Another important area where states have discretion is in the frequency or duration of the work requirement determination. The requirement is that all states have to require compliance with work requirements in the month before application. So it could just be that 1 month before the applicant applies, or it could be up to 3 consecutive months before they apply. So when we think about planning and preparation, it's important to understand as soon and as fully as you can where states plan to land on that spectrum. And then again, the good faith exceptions for states that are at risk of, or think they might be at risk of not meeting the requirement to have work requirements implemented. Will the states you're working with, do they plan to or contemplate perhaps seeking that exception for up to 2 years for when the work requirements have to be in place? So those are some of the things that the states have discretion on that we want to be watching in preparation and planning. Now I will turn it over to Linda, and I think Linda's going to get some more input from the audience.
So yeah, I think, Patrick, let's do the second polling question. Patrick?
I've got that coming right up.
Okay.
Good old Zoom, huh?
What specific area of HR1 is of most concern to you or your organization? Increased frequency of redetermination for expansion members, community engagement verification rules and processes, provider taxes and/or state-directed payments, or all of the above?
All right, great results coming in. Thanks, guys. All right. Give it a couple more seconds here. Going once, going twice. Okay, go ahead and share those results now.
Very interesting. All of the above. That I'm not surprised by that. That's good to see. Thank you so much for providing that feedback. That's very helpful. All right, so we will go on to the next section here. And, you know, as Laura and Bill both mentioned, as it relates to the complexity of implementing work and community engagement requirements, clearly there are still many things unknown. But as we've been exploring, these things will be required to go into effect at the beginning of 2027, unless a waiver has been obtained, and at the very latest, November of 2028. So, of course, these requirements are critically important. And according to Manat Health and state health and value strategies, the greater the automation to administer work requirements, the lower the percentage of loss of Medicaid enrollees. Ranked from minimal automation to somewhat automated to greatest automation, the overall loss of coverage is anticipated to be 23%, 11%, or 7% respectively. Clearly, the degree to which we automate will have a significant impact on our beneficiaries. CMS has already, of course, identified some sources to which they may be able to find information for administering some of these, income probably being the easiest source, with federal and state quarterly wage data, bank statement API services, pension data, some state unemployment and pension data, as well as some sources around gig economy work. And so we do, in fact, believe obviously this being the easiest category, and then moderate information available has to do with the education component. And there, as Bill mentioned, there may be some access to university, state, and local school system data. There is some talk about the possible future build of a national student clearinghouse, but I don't believe there's any timeline or expectation on that as of now. A combination, obviously, of the school and volunteer hours will provide some unique verification requirements. And so obviously there's still a lot of work to do. And as Bill talked about the short-term hardship issues, even with those clear-cut definitions in HR 1, there's still a lot of coordination that will have to be figured out and implemented along the way. Because even in that case, there will need to be processes in place for how that gets communicated to beneficiaries and their advocates in terms of when it applies, when it has been approved by the HHS secretary to be applied, and in fact, then when it no longer applies. And so I do believe that there still is going to be required a lot of coordination with your state partners around those factors, even the clear-cut exemption criteria. So there's still a lot not known, as states are working diligently to identify their sources of information, the methods of attaining the information, the development that they have to go through in order to use the information, and then not the least of which is the budgets to do so. So this information here, and there's more of this information available on State Health and Value Strategies website. I just pulled this information here related to the less easy categories, meaning the volunteer hours and some of that criteria. And as you can see, there's still a lot of work to be done in terms of how that process is going to be identified. The State Health and Value Strategies group does recommend leveraging Medicaid managed care plans as partners in this implementation process, as they are of great value, as they were during the Medicaid unwinding period. Medicaid health plans have robust data systems that can help to identify or flag members that might be eligible for exemptions. Claims data can identify individuals participating in substance use or abuse use or alcohol use treatment programs, and individuals that have disabling conditions. By leveraging encounter data from clinical systems that have robust clinical data exchange programs and health risk assessments, it is possible to flag individuals who may be exempt from work reporting requirements and will be a valuable resource to our state partners. States are also being encouraged to partner with managed care plans to assist members in understanding and complying with these new requirements. Clearly, there's the broad engagement, as was done during the unwinding process, of educating members and their advocates using mailers, call centers, phone calls, and federally compliant texting capability. And then there's the more strategic outreach, where managed care plans can engage for targeted groups nearing the end of a compliance window and identifying for the members qualifying activities that might help them continue to qualify. Also, by pushing alerts to primary and behavioral health care providers when patients are on the sort of at-risk timeline and nearing a period when they might be at risk of losing their eligibility. And many health plans have these processes in place today where they can electronically communicate with the primary care provider. Direct support to members can be provided through referring members to supportive programs that can help them in meeting these requirements as well. Obviously, the most complex is the volunteer hours and the combination of volunteer and work hours. There is some possible future development connections being talked about around various volunteer sources like state community services, commissions, AmeriCorps, as well as a lot of other nonprofit organizations that promote volunteer programs. I believe these are all still pretty conceptual, with open questions about scalability and what will be required for this new development, and then the funding for it, of course, will be important. So at this point, I will turn it over to Jeff, or no, Bill. I'm turning it back to you, Bill.
Great. Thank you, Linda. So I want to start by acknowledging that the status of the waiver demonstration applications we talk about on this slide is dynamic. So if this slide isn't out of date, it will be soon. States can implement community engagement requirements either through 1115 waiver demonstration programs or through the state plan. We often see that they do it through 1115 waiver demonstration processes. They're required to be in place by January 1st of 2027, but states can implement sooner at their option. And some states were already working on plans to implement work requirements prior to enactment of HR 1. 1115 waiver demonstration applications from states to CMS are a good source of information on how states are thinking about key definitions and provisions such as medical frailty, which is why we're looking at them here. And we note here that Arkansas and Arizona have contemplated defining medical frailty in their waiver applications. I'll also note that an application from another state years ago that has since been withdrawn proposed defining medical frailty broadly as cancer or other serious or terminal illness. So again, waiver demonstration applications can be a good source of information on some of these important provisions and definitions, and they're worth reading and watching. Let's go to the next slide, please. So before I get into the details of the slide, I think it's important to clarify how short-term hardships, medical frailty, and good cause exemptions all fit together. Think of it this way. States have historically thought in terms of good cause exemptions. You know, the idea of being here that there are situations in which people shouldn't have to meet work requirements, even if they're not elderly, not disabled, and so on. And this slide looks at how states have thought about those good cause exemptions to date. HR 1, in contrast, articulates exemptions in two ways. One is the required exemptions, and that's for individuals that, like I mentioned earlier, Native Americans, people who are medically frail, which isn't fully defined yet, people who are dually eligible, and other individuals. Those are required exemptions. And that's why the definition of medical frailty is so important. And then there are the optional short-term exemptions that states can offer in different situations. And so by looking at how states have viewed good cause exemptions, it's instructive for both definition of medical frailty and those optional state hardship exemptions. So on this slide, we're looking at good cause considerations to date because it's instructive. Again, with that context, we see here that many states contemplate good cause exemptions for situations like family emergencies, for life-changing events, natural disasters. And I'd note that this terminology is very similar to that used in HR 1 to describe states' option to allow short-term hardship exemptions for people who've had inpatient services in a variety of settings or where state of emergency or disaster declarations exist. Also, interestingly, you might recall that HR 1's description of conditions qualifying for short-term hardships includes the phrase "or such other services or similar acuity as the Secretary finds appropriate." So there is some opportunity to propose thoughtful definitions here. Now I'll turn it over to Jeff for more on medical frailty.
Yeah, thanks, Bill. We'll go a little deeper into this now. I'm going to do a little bit of housekeeping real quickly for the audience. There is a button on the bottom of your screen that's marked Q&A. If you do have questions, please input them there and we'll address them as we go, or at the end, I think we'll have some time for that. So picking up on where Bill left off, when you talk about the exemptions, some of these buckets are really well defined within the HR 1 bill. And I've listed them here: pregnancy, postpartum, disability, foster youth, incarceration, children, and so on. So what that provides for us is a framework or a fabric for the states to work off of as they figure out how they're going to implement. And I say state specifically because I think the states have the lion's share of the work to do in the Medicaid function within the state government to execute all of this. One of those exemptions areas, of course, is medical frailty. And as Bill said, it is not completely defined. The CMS has until June, I believe, to issue the final ruling on HR1. But I don't expect that they're going to provide significantly more definition here. And I say that because you look to history, traditionally, the federal government provides the states with the autonomy and the flexibility to implement some of these programs as they see fit within their own states. So that means you can look at it as a positive or negative flexibility, but also means the burden to define medical frailty will fall to the states, and we'll see variation, of course, across the states as they wrestle with this challenge and figure out what medical frailty means for their population. There is, however, some commonalities here that we see across states and defined within HR1. I've listed them here at the bottom. The things that we expect will be the areas that will be used for defining medical frailty. Complex medical conditions, that's physical, intellectual, or developmental, a substance use disorder, disability, sometimes including activities of daily living limitations, mental disorders, and then there is some work that has been done in various other parts of the healthcare continuum on medical frailty for the elderly, long-term care environments, so on. So there are assessments that are available, and we know some states are turning to them as the framework that they'll use for defining medical frailty. And on the right here is an example of one of them. You can kind of break, if operationally, you can break the population into three big buckets. And I borrowed heavily from Manat Health and the group that Linda referenced earlier, the State Health and Value Strategies group, in putting this together. So I wanted to acknowledge them. Ex parte renewals, as Linda talked about, is the quote unquote easiest way to do this, simply because it doesn't involve getting in contact and having the individual participate in the process. Ex parte renewal, as you probably all know, is done with available data and is done completely by the state without interacting with the individual. I put easiest in quotes because it's not going to be easy. If you think about the work that needs to be done, and I'm going to pretend I'm a state employee here for a second, if you'll give me that permission. You have to coordinate across the enrollment and eligibility system. You have to pull claims and encounter data. There's some clinical function to define what medical frailty is going to look like, and you have to make sure that you can actually execute that within your information systems. You have to be able to update those information systems. You have to make sure that what you're doing is in compliance with federal guidance. And then you have to have the ability to communicate results to various partners, and including the individuals. So there is a ton of work to go on, and I'm not trying to panic anybody. And I was actually very happy to see planning was the #1 answer on their very first polling question, because I think you have to be in the planning mode right now, even when everything isn't defined as much as you'd like it to be, and some things could still change between now and June. There's just too short a time frame to not be very engaged in trying to sort through and putting plans together in order to do a good job here of helping people through this process for work requirements and the exemptions and medical frailty. Second bucket would be existing members. Gets a little harder here, of course, because now you have to have participation from the individual. We know from our experience with the public health emergency, which I'll talk a little bit more about here in a second, that that's a challenging thing to do. It's a challenging not only because it can be difficult to reach some of these folks, but the data often is messy. And I don't mean to be pejorative when I say that. If you have any experience in anything with data, it's almost always messy. And so being able to use that data in a way to find the right people, contact them, educate them, and make the assessment will be a significant challenge. I think this is a place where really the health plans, the community partners, consultants, everyone here needs to support the local state Medicaid activities as best we can to make this as most successful and as administratively unburdensome, if that's a word, as possible. So this is going to be an area for all of us to focus on. My last bucket, new members, very similar process, but even more difficult because very often as people are coming on to Medicaid for the first time, and we're doing these kinds of assessments, the typical claims and encounter data may not be as robust. Your historical information is not as thorough. So I'm very in tune to how challenging this is going to be for all of us engaged in this and trying to help people through the process successfully. We know from the 2 states that tried work requirements a few years ago, I think it was Arkansas and Georgia, neither lasted very long. Georgia never got off the ground. The court system shut it down. And Arkansas did for a short period of time. And it was administratively difficult. That was one of the lessons learned from that. So a lot of work here to go through to try to make this less administratively difficult for the folks that rely on Medicaid. Linda, we can go on to the next one. This is a little bit of a tangent here to talk about disability and coordination with Social Security Administration. And I'll be brief here. The graph on the bottom shows the bell curve with the mean time from the time SSA provides an allowance and says, yes, you are disabled, to the time that the conversion is made in the state Medicaid office. When I say conversion, typically the change from TANF code to ABD, sometimes other codes, but the acknowledging that the person is receiving disability. So that 5-month mean time means there's 5 months from the time a person is deemed disabled by Social Security Administration to the time it's executed within the state Medicaid office. That's not unusual. That's always been that way. But now when you think about it in the context of medical frailty and work requirements, that's a 5-month period where folks are at risk. Shorter in some states, longer in others, but on average 5 months. So something to pay attention to. On the right, there's also some anomalies within individual states. We're not going to detail those here. I'm sure the states are looking at that and working through how where they have conflicts with their existing medical frailty processes or definitions, they have to accommodate the new federal guidance. And then last, as we go on to the next slide, I do want to kind of harken back to the public health emergency expiration. That, in some regards, is an analogous situation to what we're facing now, in that CMS provided some guidance and provided states with flexibility, had a year or so to plan it and to execute it. In my estimation, it was an easier task than what we're facing now. And you can see the results here. You know, this is in terms of millions of people across the bottom there. If you look at the brown graph, there was, you know, high 20 million people disenrolled, and the off-quoted 70% of those were procedural, 69% in this graph. 69% of those were procedural disenrollments, meaning people did not successfully renew Medicaid because they didn't participate, we couldn't contact them, a variety of reasons that were essentially administrative and had nothing to do with whether they were actually qualified for Medicaid or not. And then on the blue graph, there are 63 million or 62 million or so people that were successfully continued their enrollment in Medicaid. 62% of those were through the ex parte renewals, which really emphasizes that particular channel as being the most effective and again, the easiest to do. So the other things I will say about our experience with the public health emergency, it is difficult to reach people and get them involved. The data wasn't always clear, wasn't always clean, not unexpected. There was a tremendous amount of coordination required between the states, the healthcare plans, community partners, and other entities like Centauri in order to do the best effort possible on behalf of the members. And by the end of that, we were all pretty good at it. But at the beginning, we were not very good at it. And I think we're going to go through similar experiences here. It's going to take some perseverance and a lot of hard work on behalf of all of us to be successful here. So Bill, I'm going to turn this back to you now.
Great. Thank you, Jeff. So I want to zoom out a little bit here before I turn it back to Linda to bring us home. And I'm going to answer a question that was submitted, a good question that I wanted to be sure to address. So we've rightly talked a lot about community engagement requirements, and the 6-month redeterminations get a lot of attention, and rightly so. Those provisions will impact plans, enrollment, and acuity, certainly. But those functions rest primarily with the state agency. And in fact, HR 1 bars Medicaid managed care entities and certain other contractors from determining beneficiary compliance with work requirements. So to the question, yes, technically it's the state Medicaid agencies that are responsible for making the determination of eligibility, of compliance with work requirements, of whether an applicant meets the exemptions involved. But that said, as we talked about, hopefully you're imagining the ways that your organizations could try to be helpful to state Medicaid agencies as they set about this tall task. So want to talk about the other provisions in HR 1, and we highlight a few here that will have direct impact on health plans. And some of these will be challenging to operationalize, I anticipate. The first is cost sharing. HR 1 requires the imposition of cost sharing on a per service basis. It's only for certain services. And so as we think about planning and preparing, as a plan, do you understand how primary care services are to be defined, or how ER services that aren't exactly emergent are to be defined? If not, it's important to communicate with your states early and often. Also, the amount of cost share can't exceed 5% of a person's income. And that can be challenging, as you can imagine, if someone's income is seasonal, or if they gain employment or lose employment. So again, raises questions like, will states monitor income information and provide it to plans? If so, how and how frequently? It's an important point to communicate with states on and make sure that expectations are clearly understood. Another area where plans and other organizations can be can expect to need to support state Medicaid agencies is provision of address information. HR 1 requires states to get that information from plans at least monthly. So that's one thing we can begin planning for. Concurrent enrollment in multiple states. States are required to address this, and they very well may require assistance from plans. And then finally, HR 1 places higher payment error standards that put the state at risk for having to repay funds to the federal government. So this could very well translate to increased scrutiny on plans by states and more requests for help to ensure program integrity and make sure that states aren't at risk in that way. And then one last thing before I turn it back to Linda, probably goes without saying, but I think it's worth emphasizing. when communicating with states and federal partners, it's important to understand they're working through a lot, just like we all are. And in some cases, they're working with new or interim leadership, and they're working to understand HR1 and its implications, just like we all are. In some cases, they're awaiting federal guidance on details, like we mentioned. And if you can outreach through an association once rather than multiple organizations reaching out independently, that might be appreciated. And finally, of course, offer solutions wherever possible, or offer to suggest alternatives if the state welcomes them. All that said, if in doubt, it's better to communicate early and often. And if you don't get a response the first time, don't be discouraged. Thank you for that. Linda, I'll turn it over to you.
Okay. Thank you, everyone, for this information for the group. Patrick, do we have any questions that you'd like to read aloud?
Yeah, we have one in the Q&A, and let's encourage other folks too. If you have any thoughts or questions, please do send them in. Can you speak to the MCO role and the changes in immigrant eligibility as well?
Bill, is that one you feel comfortable with, or Laura, or do we want to get back to?
Yeah, I'm happy to take first shot at it and can follow up with more information after. So we mentioned there are provisions related to immigrant status in HR1. Those may be more on states and look for communication from state Medicaid agencies. And then there was the regulatory guidance that came out on September 2, and that's related to the emergency services provided to certain immigrants. And that was specific to using federal funds for sort of capitation settings. So the guidance essentially said, and of course I'm paraphrasing, is on a fee-for-service basis, it can still be okay because it's reimbursing actual services, but the regulatory change comes with regard to risk as opposed to actual provision of services. So it was looking at capitation type arrangements, and that could certainly be expected to impact plans.
Okay. Maybe one more question if you have one, Patrick.
No questions right now. I think
Okay.
most, like you guys said, most folks are in planning mode.
All right, sounds good. Well, just as a little bit of a wrap up here, so our recommendation is don't panic, prepare, which it looks like many of you are, most of you are. Agile seems like a good phrase to talk about when we think about navigating the next few years. Lean into what we've learned, understand your obligations to your partners, stakeholders, and to your members, and prepare to meet them. I would challenge us all to move from panic to the serenity principle. Yes, serenity. I think it will come in handy over the next couple of years. For those of you who know this principle, it says to grant me the serenity to accept the things I cannot change. HR1 is here. Work requirements are here. I think it cannot be changed. The courage to change what we can, work with our stakeholder partners to find useful and productive, workable solutions in the interest of serving our member community, and the wisdom to know the difference. I'm hoping that we shared some information here to help you and guide you through discerning those differences so that you can take action when and where you can to get us to the successful conclusions and helping our members. Thank you all for participating today. We really appreciate your engagement and happy to, again, provide the deck if you would be interested in it. And there will be, the recording will be available as well, as I understand. Patrick?
All right. Thank you so much, everyone. And just to repeat Linda's comments, thank you so much for attending. And we hope to see you in a couple of weeks after Thanksgiving at another webinar Wednesday for MHPA.
Patrick, I see one question I'd be happy to address. Any thoughts on the frequency of community engagement check-ins and how often the state will terminate for not complying? That will be interesting to see. As we talked about, states have some discretion. I'm speculating, but we may see that states start by implementing the relatively easier paths. So that might mean, for example, states are required to redetermine eligibility at least every 6 months. They could do it more often if they choose, as the question implies. Same's true for community engagement requirements. Again, keeping in mind states have a range from 1 month of compliance to up to 3 consecutive months. You might expect that states would start with the relatively easier process of validating that 1 month and expand once they feel like they've complied with the provisions of HR1. Again, that's speculation, but that might be something that we see. It's a good question. Thank you.
Yep. Okay, we will.
Anything else?
No, that's it. And a lot of folks were asking for the slide deck. Absolutely, you can respond to the email that sent out with my name, Patrick Core. Just hit reply. I'd love the deck. Get it to you, or contact our great presenters, who would like to thank so much for presenting to our attendees, our members. This is incredibly important. Thank you so much. And everyone have a great
Thank you all.
Thank you all.
Thank you.
Have a good
Thank
one.
you.